Hi, this is Tao Lee, Editor-in-Chief of First Aid for the UCLA Step 1. Now let's move into the respiratory physiology section. There are very important products that are produced in the lungs that will be tested on your boards. So as I mentioned in our discussion about type 2 pneumocytes, as you can see here and here, these play a very important role in lung physiology. So let's talk a little bit more about them. As you remember from the last talk, surfactant is secreted from the lamellar bodies in the type 2 pneumocytes. So what is the main component of surfactant? Well, it's mostly made up of a phospholipid called dipalmitoyl phosphatidylcholine, or lecithin. Surfactant decreases the surface tension in the alveoli per the law of Laplace, where equilibrium gas pressure equals 2 times the surface tension over the radius. Less surface tension means less gas pressure is needed to keep it open. The effect of low surface tension also serves to increase compliance and decrease the work of respiration. Later on in this section on page 569, we'll talk about neonatal respiratory distress syndrome, where you have insufficient surfactant at birth for efficient respiration. So what do prostaglandins in the lungs do? Well, prostaglandins, specifically PGF2, sorry about my handwriting here, can cause bronchoconstriction, while PGE2 and prostacyclin, or as you can call it, PGI1, can cause pulmonary vascular dilatation. In fact, as we'll discuss later on, synthetic prostacyclins are a treatment for pulmonary hypertension. Histamine is a smooth muscle bronchoconstrictor. However, antihistamines have not really been shown to be useful in disease conditions with bronchoconstriction, such as asthma. Now let's talk a little bit about angiotensin-converting enzyme, which is really only found in the lung. Recall from the first aid renal physiology section that this is a component of the renin-angiotensin-aldosterone system, which is involved in blood pressure regulation. ACE converts the renal product angiotensin-1 to angiotensin-2, which then goes on to stimulate release of aldosterone from the adrenal medulla. Since this increases blood pressure, of course, ACE inhibitors are used to treat hypertension. Unfortunately, since ACE also is required to inhibit bradykinin, one of the possible side effects of ACE inhibitors that we see is that they can increase bradykinin and can cause a classic dry cough and a swollen lip, and maybe swelling elsewhere. Alrighty, let's talk about lung volumes. Lung volumes are guaranteed to show up on your exam, so you should know these things backwards and forwards. Plus, really in addition, lung volumes will come up frequently throughout the rest of your medical school education and medical career in almost any field. So first, let's describe some of these terms. Lung volumes are these 4 individual measurements labeled by the boxes on the left side of this figure. Residual volume is the air left in the lungs after maximal expiration. The expiratory reserve volume is air that can still be breathed out after normal expiration. The tidal volume is the volume air that moves into the lung with each normal respiration. This is an important parameter when establishing the efficacy and therapeutic nature of mechanical ventilation. And finally, the inspiratory reserve volume is the amount of air that can be inhaled after a normal inspiration. So what can affect these lung volumes? Well, lung volumes tend to be greater in tall people, smokers, and people who live at high altitudes. So keep those factors in mind. It's also important to understand how the different lung volumes are related to each other and how each can be determined. A capacity is made up of multiple volumes and labeled by the arrows on the right side of this figure. So the vital capacity is the tidal volume here, plus the inspiratory reserve volume and the expiratory reserve volume. Here we go. So it's basically everything except for the residual volume. And again, this pretty much represents the total amount of air you would breathe in if you first exhaled as much as possible and then inhaled as much as possible. Functional residual capacity is the volume in the lungs after normal expiration. So which volumes would comprise FRC? Well, that would be residual volume and expiratory residual volume. On the other hand, the inspiratory capacity is the tidal volume plus the inspiratory reserve volume. Okay, finally, how do we determine total lung capacity? Well, that's basically everything. So inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. The whole shoot and match. So what happens to lung volumes in lung disease? Well, we'll discuss this in much more detail on page 568, but you would see decreased lung volumes including forced vital capacity and total lung capacity in restricted lung disease, whereas with obstructive lung disease like COPD, you see increased residual volume at the expense of less forced vital capacity, so this area is smaller, because of air trapping. Okay, recall from our respiratory anatomy talk that dead space does not participate in gas exchange. So if that's the case, what's physiologic dead space? Well, it's anatomical dead space plus a functional dead space. As you know, the conducting airways contribute to the anatomic dead space, serving to conduct air to the alveoli involved in gas exchange. So what's functional dead space? That's where you have alveolar ventilation but no perfusion, so therefore no gas exchange. And an example of that would be what? Well, that would be the apex of the lung. Anatomic dead space tends to be fixed, but functional dead space can be significantly increased in conditions such as COPD, where you get the classic ventilation-perfusion mismatch. Physiologic dead space can be estimated by using the Bohr equation, where VT is tidal volume, PaCO2 is the arterial CO2 content, and PeCO2 is the content of CO2 in expired air. This makes logical sense because only ventilation involved in gas exchange produces CO2. So the closer that CO2 in the expired air is to the arterial CO2, pulmonary arterial CO2, the less physiologic dead space ventilation you have. You can keep this all straight with the mnemonic taco, paco, peco, paco. Let's talk now about the mechanics of the lung and chest wall and how their characteristics influence pulmonary physiology. The story here is lung compliance, which we will talk about in a bit. Over here, you have a schematic representation of the balance of static elastic recoil forces in the respiratory system. You can see here the static volume pressure curves for the chest wall, the lungs, and then the combined respiratory system. Please keep in mind that the distending pressure or the pressure you need to expand or shrink the respiratory system is simply the sum of the distending pressures of the chest wall and the lungs. Again, from this diagram, you can see that there's a tendency for the lungs to collapse inward and the chest wall to spring outwards. When the lungs are at their functional reserve capacity, the inward pull of the lung is equal and opposite to the outward pull of the chest wall, and the system pressure is the same as atmospheric pressure. At this point, the airway and the alveolar pressure are both zero, and interpleural pressure is negative. By the way, why is it good to have negative interpleural pressure? Well, negative interpleural pressure helps keep the airway open. Now over here, this is where the distending pressure of the chest wall is zero. And at this level, we call this the resting volume of the wall, and it's about 50% of vital capacity. This directly ties into the concept of compliance that we mentioned just a little earlier, where compliance is defined as the change in volume for a change in given pressure. So higher compliance means that the same pressure change will create a larger volume change. So what's the inverse, if you will, of compliance? Well, that would be stiffness. The slope here is a measure of the compliance. So as you can see where the slope is steep, or steeper, you have the most compliance. You tend to have more stiffness, or less compliance, with extreme volumes, and therefore you see a flatter curve.